Every day, nearly 50,000 people around the world hear 3 words that change everything. You have cancer. 1 in 2 men, 1 in 3 women, behind every number, a life interrupted, a story rewritten. This season, we turn our focus to the fight of a lifetime, cancer. At ASCO 2025, I sat down with 3 of the most powerful voices in oncology.
They've authored now over 1,000 publications and are presidents of oncology's most outstanding professional organization. I'm truly honored to introduce you to Dr. Lillian Siu, the senior medical oncologist at Princess Margaret Cancer Center in Toronto. Dr. Howard Skip Burris, president of Sarah Cannon Research Institute in Nashville, and former ASCO president. And Dr. Fabrice André, Director of Research at Gustave Roussy Cancer Campus in France.
This is where science becomes action, where innovation meets impact. This is the future of cancer care. This is Doctors Unscripted. Now let's get started. Thank you, everyone, and thank you for coming. I'm going to ask you a question that's probably the hardest question for the day. And it's about, when you were in med school and you had those colleagues that you knew exactly what they were going to go into, what did your friends or colleagues believe you were going to go into, and why did you choose oncology? And as you're telling us this, I would like you to introduce yourself. What do you do, your institution, and then why? I'll start with you, Fabrice.
Well, first, thanks a lot for inviting me. So my name is Fabrice André. I am a medical oncologist working in Paris, France. And so when I was in medical school in Grenoble, that is a city in the French Alps. I was doing ski racing. I really wanted to do sport medicine. I was fascinated by sport, physiology. But then, when you grow up in medical school, step by step, you see the patient, you want to improve their situation. And also, I became fascinated by, molecular biology. At that time, it was growing. So then I switched to medical oncology.
Got it. I thought, now, you did mention something about hematology as well.
Indeed. I love hematology. I wanted to do hematology. I was doing some ski in New Zealand, so I asked a friend to take my fellowship, and he took the medical oncology. It's okay, I owe him a lot of things,
No, thank you for that. What about you, Lillian?
First of all, thank you for having us here. It's going to be fun talking to friends. I'm Lillian Siu. I'm a medical oncologist at Princess Margaret Cancer Center in Toronto, Canada. I wanted to be an oncologist from the get-go, so I basically took all the rotations that everybody has in oncology and did it and trade off their other rotations with me. So it was pretty much a interest from the get-go.
Yeah, and what about you, Skip? Okay.
So Skip Burris, I'm an oncologist at the Sarah Cannon Research Institute in Nashville, Tennessee. I came out of college at West Point with loving engineering, math, and economics, and I went off to medical school, and it was an exciting time for cardiac surgery. They were doing the initial bypass surgeries and transplantation, and I traded some rotations to do more cardiac surgery. It was really exciting for a while. And then the lack of patient touch continuity bothered me, and I was a little nervous about what I was going to end up picking. And as I went through the various rotations, I found that I loved the oncology patients, I liked working with the oncologists, liked the oncology nurses, and I really picked oncology as a career because they say you want to go work with people that you love to work with, and that was a big part of the decision, and sort of learned the science after the fact.
And you, Tania, did you know which medical specialty you wanted to do when you were at medical school?
You know what? I thought I was going to go into OBGYN. I loved it. I was watching these babies being delivered, and I wanted in. And I remember even during, during the third year of med school, I was like, I'm going to do all the deliveries. And then I realized that that's not the piece that I enjoyed. It was actually looking at life and the potential of life. So I quickly moved from enjoying deliveries to actually the humanity and the human being that I wanted to treat. And that was, that's what moved me in to medicine and then oncology. So this year ASCO was filled with, transformative data across the board. Out of all the sessions you attended, which data do you think is going to have the most impact over the next 12 months? And I'll start with you, Skip.
You're right. There was data everywhere, exciting news everywhere, but this year, and it's not always the case, but this year, the actual plenary session had presentations that are going to require our colleagues to go home and make a decision about how they're going to incorporate that information. The room was packed. I was joking, even the bathroom lines were long, like we were at some major sporting event. And yet, as you went through the presentations, large trials randomized with answers that said, am I going to incorporate immunotherapy into the adjuvant, neoadjuvant setting? Am I going to consider switch therapies in breast cancer? Am I going to do the biomarker and molecular profiling that we really should be doing for more patients at the time of their initial surgery to impact what my treatment decision will be? So I felt like all the presentations from that session, the oncologists around the world need to think about those results, and there's not a right or wrong answer, but make a decision about how they're going to use that information to treat their patients.
Yeah, and so in that case, what do you think for you, because you're still in practice, what do you think you're going to take home and I guess incorporate?
So I have been beating the drum about not saving testing, not saving therapy. I've always believed better treatments, better testing, better therapies would come along. And so I'll go home and use this to continue to reiterate what I believe is you ought to do the best testing and broadest testing on your patient as early as possible, and you ought to consider utilizing those new therapies where there's data early on, not be a saver of a treatment.
I completely agree. What about you, Lillian?
I'm a head and neck medical oncologist, so there have been, for the first time, 2 positive studies in head and neck cancer.
Yes.
One is Keynote 689 that was presented in AACR, and one is Nivo post-op that was just presented at ASCO. One is perioperative immunotherapy, one is essentially adjuvant immunotherapy. So I think when I go home, we're going to actually literally have a meeting with multidisciplinary specialists, ENT surgeons, radiation oncologists, medical oncologists. We already planned that meeting on Friday coming up to discuss what are we going to do. I'm not sure we know the answer, and it will be a very interesting discussion. I think the other abstract that I was very interested is the Canadian abstract, if I may showcase Canadian work, is Chris Booth's study about exercise in patients with stage 3 and high-risk stage 2 colorectal cancer, that it was able to reduce death by 30% in follow-up for these patients, in addition to all the standard treatment that they have had. And it's a cancer-specific survival, that they actually did not die from their cancer as a result of an exercise program. So I guess the question is, can we extrapolate this to all cancers, if that works for one cancer? So I think those 2 things are going to possibly change my practice.
So what you do in Canada, can it be incorporated into the rest of the world, particularly the US? Will we be able to get folks to follow this advice?
Well, I think exercise is I was going to say as easy as not easy. It's hard to make somebody exercise because you can do it for 2 weeks, but you're going to do it for 2 years or 20 years.
Right.
And that kind of, and that's why there was a coach involved in the study to actually have somebody supervise and encourage you. I'm not sure without one it's that easy to implement. So we'll see.
But
maybe
then also,
you need a coach every person in America.
Great idea.
But then also, how do you pay for that, I guess, is the other question. So we have now these different dietary changes as well as lifestyle changes, but then how do you incorporate that? Like, are insurance companies going to pay for it? How do we?
That's a good question.
But I think Tania, there are ways to develop medical device on this topic.
Yes.
With digital medicine,
Yes.
Wearable. Maybe in the future, the oncologists will check, the acquisition of the data from a wearable of the patient with a kind of a digital coach saying how much exercise the patient will do and has done. I think there are two questions that are really important in this. Is first, what type of physical exercise improve the outcome? I mean, it's not all the same. Is it anaerobia? Is it, and the second one is, what is the mechanism? Because so if we understand the mechanism, well, maybe we can also develop some drugs that will improve the outcome even better.
Yes.
So in fact, it's eye opener, but it's also door opener. We are opening a totally new field. Maybe it's going to be about cancer metabolism. I don't know, but it's a very important study. I have to say, my first one was the head and neck presentation. The second one was the one on physical exercise. So in 30 seconds, I had to find what was the third one. So I think I will select the one on trastuzumab deruxtecan in patients with metastatic breast cancer with the overexpressed HER2. It's a first-line setting. The median PFS is around 40 months. And then I was discussing yesterday with colleagues and said, let's go back in the past, 2001, with the New England Journal of Medicine first randomized trial, chemo versus chemo plus trastuzumab. The PFS was 4 months for chemotherapy. So it means that in around 20 years, we moved from 4 months progression-free survival, disease control, to 40 months. So it just tells us that, with the knowledge of biology, the development of biotechnology, well, we can really have meaningful improvement for patients who are living with metastatic cancer. So when I was fellow, metastatic cancer was meaning death in a few months, Now, the first line, disease control is around 40 months in some subset of breast cancer. I think the number was impressed me a lot, this 40 months.
I completely agree. And even in terms of, I'm going to switch now to diagnostics, and I'm curious to get your thoughts, and I'll start with you, Fabrice, on all the data in terms of liquid biopsy. And obviously we've been talking about it for years and years and years, but even leveraging ctDNA to determine prognosis, as we saw with I-SPY data, or in terms of switching, as we saw with Serena-6. So out of curiosity, what are your thoughts, please?
Circulating tumor DNA, meaning these are fragments of the DNA coming from the cancer cell that are released in the blood. So by a blood test, we can detect this fragment of DNA coming from the cancer cell. Why it's important? First, because from the analysis of circulating tumor DNA, you can detect the mutation that can inform you on which treatment the patient should receive. Maybe we can agree that this is almost standard of care. I mean, even in France, we do it routinely for patients. The second application is early detection of cancer or early detection of relapse. And this is where I think we are going to have a discussion. Is it yes or not ready for to be used? The third application is the opposite, is when the patient has a cancer, whether there is a clearance of the ctDNA. And if there is a clearance, it means the outcome is good and maybe we can decrease the burden of therapy. There was a fantastic study in colon cancer where they could show that after surgery and local therapy and adjuvant therapy, and before adjuvant therapy, if there is no ctDNA, it's possible to de-escalate and to reduce the amount of treatment. So that are the three use cases. I think it's level 1 evidence for detecting mutation.
Yes.
There are some very convincing randomized trials in colon cancer to de-escalate treatment, meaning no adjuvant chemotherapy if there is no ctDNA. And the question today is, if we detect ctDNA, rising ctDNA, before the relapse of the cancer is detected by imaging, is it useful or not?
Right.
So I think that the results that were presented are promising. I think maybe it's a little bit early to conclude, from my opinion, that the detection of ctDNA before relapse on imaging really improved the outcome of patients. The drug that was tested in this trial called Serena-6, that is camizestrant estrogen receptor degrader, is effective. It's not the discussion. The discussion here is it ctDNA detection before relapse on imaging useful for the patient. I can see Skip is ready to talk.
So
I think we are going to make a comment.
Make sure you get a chance.
So
Yes.
the floor is
No,
yours.
I was And you took the 8 hours and condensed it down. And I was leaning in because the idea of saying so much with fewer words is impressive. And I think you outlined it into very nice segments. So no reason to repeat that. I think the challenges that I see in my world at Sarah Cannon communicating and working with community oncologists is justifying how often to do it. That gets into the price, but we need to get it to a place where we can do it frequently. I think the other part, which is a little bit of a hurdle, is handling the information and then being forced to make that decision. Oncologists want get this result, do this therapy sort of thing. Getting some rhythm and guidelines on how often to do it is where we need to go next, but great overview summary.
I want to interject too. I think I have 3 points. One is I think the assay matters. Not every assay is made the same, and not everybody understands it out there, that if your assay is not sensitive, even if it's negative, it does not mean you have no residual cancer. So I think the assay is very important. And looking at the dynamic study in the colorectal cancer, the de-escalation seems to be a possible way forward, but the escalation is much more difficult because obviously in that study, Dynamics 3, they escalated by adding a more intense chemotherapy. Right. But probably it didn't help because there's cross-resistance and the drugs matter. What you're going to do when you have the positive ctDNA result really is important. So I think if we think that one size fits all, just because you detect MRD, you add more drugs, it will work. I think that's a fallacy. It's not going to work. So I think these are the nuances that we have to think about when we think about ctDNA, molecular residual disease, switch therapy. I think there's still a lot to be learned.
A lot of people think that the future transformation of oncology is going to come from early detection of cancer by blood tests. If this happens, I mean, the life of patients is going to be dramatically transformed. Maybe we'll be able to early detect pancreatic cancer, liver cancer, highly lethal cancer. So probably in the next 2 years, we will have results of very important studies on this field that can potentially transform oncology and the life of millions of patients per year. So we are really looking forward for this.
I just want to add one thought to that, and I'm aligned. We've done a lot of work at Sarah Cannon with those various clinical trials, and they've been attractive and people are interested. And Fabrice said a key thing about the highly lethal cancers. I think we've got to focus there. If you can pick up a pancreatic cancer early, people get focused on breast and prostate that are slower growing, and we've got more treatment options, and does early detection really make a difference, which I still think it does. But the early endpoint on highly lethal cancer should be where we really judge those tests.
But then, okay, so let's talk about that. So if you think through, to your point, pancreatic cancer, who do you know to screen? How do you implement something like that?
You describe a great challenge, and we, in participating in the trials, we've had some great anecdotes of picking up a few patients and went to early surgery. But the fact is, upper socioeconomic folks are who's using the test commercially right now. So we don't have the answer to your very good question.
I think that was one of the things I wanted to explore as well. We look at our different environments. And we talk about liquid biopsy, and if that's the future, how do we get it implemented for you in more of the rural community, for you across the lower middle income countries, and which is a big focus of yours? How do we get that implemented within our communities?
Well, I think in Europe, Tania, the biggest problem here is the lack of market for diagnostic tests. If there is no market, there is no private investment, so there is no new device. So I think the next step for Europe in this topic of precision medicine is really creating a market for diagnostic companies.
And the only thought I'll add to it, and you alluded to it earlier, Tania, is this is a place to bring the payers to the table, because treating earlier should be certainly much more cost effective than. So having them participate in this will be key.
I mean, we can pull out all the economic models to show, right? If you can do much more preventative care or diagnose early, treat early, you're saving a lot of money in the back end. And one of the things I was thinking about are these early studies. If you think through phase 1, there's been a lot of discussion about, obviously we've been doing a lot of adaptive designs, but how do we move faster, shave off a lot more time, especially during this time, but yet hold true to the scientific rigor? So curious to get your thoughts.
Yeah, I think obviously there's a competitive market where when you do your trial, you want to not share that data until you're finished. And I think when your study is finished in early phase, I think that data should be shareable because it's sort of the hopefully post-competitive phase that you are able to actually learn from each other. And how many drug X targeting, target Y out there? Many. And we know that, for example, companies all have very similar pipelines. And yet, by the time we hear of 5 of them or 6 of them fail, you still have 4 or 5 of them going on. And that data is not shared. That data is not learned. And I think it's a pity that we're not able to do, a lot of iterative learning on negative data.
Yes.
I understand positive data is hard to share. Yeah. I think negative data can be shared. That will eliminate us not wasting our time, our resources, and obviously our patients' time to go into studies that probably has a very, very little chance of succeeding. And I think one of the areas I'm very interested in is how we can actually leverage preclinical, published, cell lines, models, AI, whatever it be, on clinical trials and real-life evidence, and post-clinical trial real-life evidence, and actually keep learning as a model. Maybe we can do more federated learning. You don't send it out, but you can train your model locally and then feed it to the world. I think that's the only way we can actually learn quickly together.
I think the way you can also accelerate things is through cancer classification. Our cancer classification had been done for local treatment. Now we are in the era of molecular oncology, meaning any drug is targeting a specific protein, specific molecule, specific process. For me, it does not make any sense. We say, look, we start with melanoma, 2 years after we do kidney cancer, 2 years after we do lung cancer, because the molecular determinant of drug sensitivity are the same in a lot of cancers. So we should really move, in addition to organ-based classification, to have molecular-based classification, going pan-cancer or multi-cancer. I think that could dramatically accelerate drug development. If we look at anti-PD-1, for example, it took more than 10 years before some group of patients defined by a disease, defined by an organ, got access to anti-PD-1. But again, the molecular determinants of sensitivity of anti-PD-1 were exactly the same as the melanoma or kidney cancer or lung cancer. So I think that could dramatically accelerate drug access.
How do we change that? Because most of us are focused on a particular tumor type, right? Even in terms of practice. So how do you make that paradigm shift?
I think this is the work of scientific societies, ASCO, ESMO. These are very strong stakeholders, So if tomorrow these organizations are saying, look, in addition to the conventional way of classifying cancer, we can agree on another way to classify cancer based on molecular alteration, and of course AACR can be a major player on this question as well, that can really change the field dramatically and accelerate. And of course, regulatory agencies have to be involved in this switch of classification. But in our analysis, we think it's a major challenge for drug development.
A lot of the problem is that it's not funded in many jurisdictions. Right. NGS is just not available on every patient. So it's challenging. I completely agree with Fabrice that we need to learn not just on histology, we need to learn about the biology. Yes. And yet NGS is not available, so you only have half of the equation, and it's hard to contribute data when you don't have the second half. And I think that's something that perhaps the funders and the payers need to think about, how to actually make it more available, perhaps especially in cancers where there are actionable targets. Right?
Going back to what we were all saying, if you're going to fail, fail fast, right? And that helps everybody, saves resources, patients don't go on effective therapies. The other thing I comment on, going to the NGS piece, if I'm a pharma biotech with my drug, I want to know everything I can about that patient so that I can then, and this is where AI and other analysis can come in, why didn't it work in those groups? So people say, well, give me an example. I mean, go back to many years ago. If we treated trastuzumab for everybody, it wouldn't have gotten approved if we hadn't found the subset. Cetuximab struggled till we realized that there was a whole group of colon patients with KRAS that weren't going to respond. So, there's simple examples like that, and now that we're with better agents, better targets, better understanding, it should even be more relevant. We should have dozens of those examples, and we probably do.
And that's what I was going to ask next, because obviously there's been a lot of companies talking about AI and leveraging AI to do better predictive modeling, to understand resistance much better. Who are your responders, who won't respond? How can we start using AI to develop better studies, to develop better drugs?
I mean, AI is such a buzzword. Everything is like AI, is like everything tastes better with bacon on it. AI is everything that looks better when you have AI in your design and your model. And I think we're still at the learning stage of how to leverage AI, and yet the learning curve has to be really steep. To be honest, I think it's a good time because we have technology and biology really both side by side each other, and they're racing to be, which one is more, relevant, and they both are. And I think we have so much data that we can feed into these models, and the important thing is to really understand when the output is correct or not. And I worry about hallucinations. I think the future is very exciting with these digital pathology, AI models, generative AI models, but we just need to be a bit cautious in the output.
So on the AI front, though, diving in, but I have our molecular team continually provide me slides that are called the perfect patient. So I'll give you two quick examples that I just gave at a recent lecture. The perfect pancreatic cancer patient for a trial. They had a very specific KRAS mutation that this biotech company desperately wanted. At the same time, they were MTAP deficient, so they were the perfect patient for the PRMT5. And so, what trial to put them on? And both those companies are going to judge in a silo or a vacuum. So then, Fabrice, I had a patient, classic estrogen positive breast cancer patient. Then our molecular team pulled out from one of the sites who had a TMB over 100. So we don't give immunotherapy to an estrogen receptor positive breast cancer patient, but with a TMB greater than 100, she was the perfect patient for several IO trials. Right. So what is it about you're going to need AI to understand.
Combination, that's what I would say.
Right. So AI's got to hopefully help us figure out that all these patients, we've proven with NGS that every patient really is unique.
Yeah. So as we were talking about AI, and one of the things that I'm really curious about is how do we leverage AI to even understand our responders versus non-responders, and use that much more to predict. So how do we leverage AI to get smarter about that?
So it has to be taught. And the only way it can learn is we give it data from experience, real world, negative trials, positive trials, and it keeps go on to an iterative cycle of teaching and learning. And I think this is why this kind of process of having data sharing is really important in my view.
Tania, this is going to become a major role for academic institutions. That is, the issue with AI that they need large number of high quality data. And this can only be delivered by institutions who are committed to provide data of very high quality. So this work of generating data is going to be more and more important. Then I think about AI. Of course, is going to probably to transform oncology. Still, we need to be realistic. We still need brain to invent, discover what is a new dimension of biology that is important, being able to design the experiment on a way that the AI will not be able to do it. So I think I'm very optimistic about AI. Is the only thing that we need to rethink the role of academic institutions in this new era. Plus, we all have to realize the most important predictor dimension of biology is the one that has not been discovered yet. And this is still in the hands of the human nowadays.
And I'll just add, the one hope I would have for AI is if we think about novel endpoints. We're at a place now with some diseases, there'll be continued fights of do you have to show overall survival, but with certain mutated cancers where people are going to do well for years, or even thinking about tumor classifications like CLL or some of the bone-only prostate breast, it's just not realistic for us to wait on advance for survival. We've got to have other endpoints there. And the other point I would bring up is the parts of the human condition that are affecting these therapies. The fact that patients that are overweight seem to do better with some of the immunotherapies. There's other biologic characteristics that we need to accumulate all that data, and hopefully AI can sort out what some of those issues are as to why people do better or not.
Since you went into overweight, healthy living, I want to actually talk about that because, like I said, that was a big focus for ASCO. And we know that weight gain, smoking, we know sedentary lifestyle all contribute to increased risk of cancer. What do we know about lifestyle and its association with cancer, and what should we be doing as healthcare providers?
Well, I think the obvious ones are the ones we already know. Smoking is bad for you, and drinking a lot is not good for you. I mean, for the cancers that we already know. But I think for the new areas, like exercise seems intuitive, but the mechanism, like Fabrice said, is not clear. It's not because they become healthier just because they stop drinking and doing good things. Because it's the cardiac risk is not changed, for example, or it's similar between the two groups. So I think we have a lot to learn. For example, my psychiatrist in my hospital is very interested in people in distress, their psychological condition affect their response to immunotherapy. What's happening to your cytokines and all your, enzymatic metabolic systems. These are complete unknowns to us, and we spend so much time on tissues, blood, and everything else. We forget about some of these other areas that are probably much more challenging, to be honest, to measure. And I think they do factor in terms of treatment and responses and resistance.
Absolutely.
I think, Tania, maybe 2 points on this topic. First, a major component is social determinant of outcome. We have a French epidemiology study, and I has been fascinated because each time we address a question, we always see social determinant of outcome coming first to predict toxicity, quality of life, deterioration of quality of life, etc., etc. So this is a very serious issue that for oncologists, we don't have this in the radar, so we need to create awareness on this question of social determinant of outcome. The second thing I wanted to mention is all the work from Crick Institute about the role of macrophages on cancer promotion. This can be really transformative on the way we even perceive the cancer, because maybe we can modulate this by blocking IL-1 or different other mechanism. So this is very important, but also maybe we can predict. But more importantly, it's going to totally change the way we classify disease. Mm-hmm. Maybe tomorrow we will see, everyone, you have high level of chronic inflammation. Mm-hmm. You are predicted to develop cancer, cardiac disease, neurodegenerative disease, etc., etc. So probably the trunk of the disease is going to be shared between many, diseases. So these things of myeloid cell, macrophages as a determinant of and predictor of further disease is going to be something very important for the next decade.
And you're right, because I think every therapeutic area is exploring that. And as you guys know, I did a show before on Alzheimer's. You're going to hear us talk a lot about that and inflammation, its prediction, and its prognosis when it comes to Alzheimer's.
I want to ask you, with obesity, do you think GLP-1 agonist is going to have a big role in cancer reduction, cancer mortality change?
So with the dramatic uptake of those drugs, we should be able to have an answer in the very near term. And you would think that that's a place where AI could help if we can aggregate the data quickly as to have that level. And then the next step of that I was going to comment on a minute ago is part of that success going to be reducing the markers of inflammation?
Yes.
And is it going to be reductions in stress and being able to measure that? Because a common question I keep getting asked by colleagues and friends outside the profession is younger individuals getting cancer. And I think we used to consider that anecdotal, but now it seems to be clearly a prevalent issue. And so environment, diets are part of that. But much of the tools we have now allow us to lead pretty sedentary lives. And then it also feels like stress is higher than it's ever been. And so measuring how those are part of the impact has got to be part of the story.
And even as we continue to talk about health, there's a big discussion about microbiomes, right? And I know there's some recent data even shown that even with when it comes to resistance of, for example, PD-1s, and once you change the microbiome and once you change the environment, you get better sensitivity. What are your thoughts on this?
So it's a shout out to my wife and I gift a Young Investigator Award every year.
Yes.
And we've had one of Lillian's outstanding researchers be a recipient. This year, our award winner is a researcher out of California who's studying exactly that. And we don't pick the project, the review committee does, but she's studying the fecal microbiome with the tissue microenvironment from patients who relapsed on the neoadjuvant checkpoint inhibitor trials, because that did pretty well, but what was it about that group that didn't get the success? And she's got some information suggesting that the microbiome there might really be a factor to, so a key point we've got to study.
But I think, Tania, I agree, it's interesting. What we are missing still is a large randomized trial saying, oh, if I do fecal transplantation, I change the outcome of the patient. And the day we have it, suddenly it's going to attract a lot of attention, a lot of investment, new clinical trials, and then it's going to grow dramatically. Today it's a little bit looping a little bit, so we have a lot of retrospective studies. There is something happening, but it's difficult to decipher exactly which bacteria is important, which network of bacteria. So I think we still miss this big data showing clinical utility, and then things will go very fast and very broad.
And maybe someone, just for our listeners, if someone wants to explain what the fecal transplant is.
There are different ways to do it. You can take sort of stool from patients who are very good responders from one immunotherapy drug and give it through colonoscopy to another patient who is going to receive immunotherapy in the hope that you're going to directly transfer good organisms into their gut so that they can actually have a higher chance of responding to immunotherapy. As you said, there are oral formulations that can do the same. Either they're in the form of bacteria or encapsulated stools or different formats.
And thank you for that. So we're going to talk about disruption. So when we think about disruptors in the field, we're looking at different modalities, whether it is ADCs, bispecific, trispecifics, protein degraders, radioligand therapies. There's a lot happening in this field. What excites you the most, and where do you think the field is going to go next?
Lillian, I'll let you go first.
Okay. It's hard to predict which one will. It's probably going to be combinations thereof. I'm excited about vaccines because I'm interested in the molecular residual disease space. So I think in that group, it's hard to give somebody who has molecular residual disease prolonged, intense, toxic therapy. So I think the attractiveness of having a personalized therapeutic vaccine is very exciting. And obviously, we already have preliminary data from some diseases, pancreatic cancer, kidney cancer, that perhaps we are able to trigger enough of immune response to perhaps eradicate and intercept in those patients with high-risk disease that we just talked about with detectable ctDNA. So I think I'm very excited in that. And that data still needs to be matured through randomized trials. It's still a bit early. But certainly, I'm very interested in following that path.
Yeah, no, completely agree. What about you, Skip?
I would echo the sentiment on the vaccines. I think we had some early starts that were too broad. It's going to get more specific, and going to minimal residual disease, early adjuvant therapy, that's going to be the place to really study those. I'll throw in that I've been amazed by how quickly the bispecifics, and now you're hearing about trispecifics and bispecifics to bifunctionals, and having had some experience with those and seeing those therapies overcome resistance to traditional therapies, I have great hope for that. I have great hope for, it's that ultimate combination of science and engineering. One of our common mentors, Dan Von Hoff, always said that he thought engineering would play a big part in curing cancers, and I think he's going to be proven correct again, that the engineering is going to help us have the better molecules there.
No, I fully agree with what has been said. I think biotechnology
Yes.
are going to change cancer care, but we all have to keep in mind, and as Skip was saying, we can improve drugs only if we understand the failure and the mechanism of action. So that put all the academic colleagues at the center of the research, because we need to understand from patient sample what's wrong, what's right, to go next step. Maybe then 2 points. First, I've been quite impressed by radioligand therapeutics.
Yes.
I think it's going to grow. We still don't know how it's going to be implemented, a lot of work, but it's here, it's going to grow. And then the second thing, because you talk about disruptive, it's something that we would like to do since 5 years. We don't know how to move it forward. But more and more, we are going to a situation where we can really model the biology of cancer in each patient. The logical next step would be to create a drug per patient,
Yes.
So if you understand the mechanism, you understand the protein, we have AI to design drug. We are not so far to create one pill, one antibody, one complex drug for patient. The only issue is the time and the price it would cost. But I think as a concept, we should start working on this.
Do you think on the radioligand front there's enough targets that are going to be suitable, meaning tumor specific, not found on normal tissue?
I think, so first there are a lot of work on this topic, so I don't think we have a clear answer to date. I think the biggest institutions in the world are working on what they call surfaceosome, so discovering new proteins that are specific to cancer. And maybe we will have some surprise. Maybe some proteins from retrovirus are overexpressed in cancer cells. Then the question you're asking is a very interesting question from a pharmacology perspective. What do we call a normal tissue? And finally, do we need to compare the protein of the cancer to any normal tissue, or should we just spare the most important tissue like heart, kidney, brain? And I think this question for me is unsolved, but it's a crucial question if we want to discover new cancer-specific target. I don't think we should compare to any normal tissue. I think we should limit to the tissue where if you target this organ is going to create major toxicity.
I mean, that's going to be relevant for ADCs. It's going to be relevant for CAR-Ts. I mean, I presume knowing what is expressed on the surface, what internalizes, which one's functional, which one's not functional, and all the, normal versus non-normal distribution.
And I guess I didn't clarify my question. That was a great answer, and I agree with it, and I feel better hearing you say that. And when I think about an ADC, you think about off-target chemotherapy effect that will go away, as opposed to we always think of with radiation, that once we've done it, it's done. So is there going to be a different level of concern? But I certainly share your sentiments, and I think you get to a key point about there's organs we must protect.
Well, that's why the payload in these drugs are going to be very important, whether they're going to have like a very short distance and not damage, your deep organs and the half-life, right?
Yes.
Yeah.
Throughout this discussion, we've been talking a lot about sharing data, understanding both from an academic standpoint, from a society standpoint, from even a pharma standpoint. How do we work together? We understand, obviously, the environment has changed. And let's be clear, there's less funding for research as well. How do we work together so that we don't drop the ball and we continue to move research forward?
Yeah, I mean, if you think about it, patients want to share their data.
Yes.
100%.
Yes.
Physicians want to share their data, for sure, because we all want to learn to see what is going on, and we don't want the field to move very quickly. We wouldn't want it to stall. So what are the barriers? I think a large part of it is legal. And I think we need to work on how do we overcome the legal concerns and legal barriers. Of course, we want to provide privacy. That's completely understandable. But at the same time, there are many ways we can do this kind of sharing without breaking these privacy concerns or similar concerns. And I think this is where we really need to work that framework that everybody feels comfortable, and yet we can move the field much more faster than we are now.
Agree. We've got to empower the patient. There needs to be some standardization of when you're moving into the situation for the first time with your physician, that you agree to share your data with the appropriate provisions to protect privacy. I mean, the data is the patient's. Yes. There's intellectual property on drug development and those factors be brought in, but it's the patient's data. They're going to benefit from sharing with each other, and we've got to continue to push that initiative.
Yeah.
I think, Tania, I fully agree, of course. Regulation, especially in Europe, is a major barrier to share the data. But I wanted to add something else. We should also add in the evaluation of academics, whether they have contributed to large database, how many download, et cetera. Myself, I had my team evaluated, a few times ago. We have added in our evaluation how many times our data were downloaded by external teams. And the evaluation committee was very happy with it. So I think it's also about, leadership of organization, institutions, scientific society to reward people who share really the data.
And I'm going to shift to something that I think is near and dear to all of our hearts, and that is looking at access for patients. Because obviously, no matter what kind of innovation we bring forward, no matter what kind of breakthroughs we bring forward, if it's not reaching patients, then eventually it's for naught. How do we work to improve access? And I'll start with you, Skip, since I know that, again, you work in a lot of rural communities. How do we ensure that our medicines are reaching the patients, our studies are reaching the patients?
It's a critical issue, democratization of care, access to care, and it goes beyond even race and socioeconomics. I mean, sometimes it's geography, sometimes it's social support system that the patient has. All those factors play together. So we've got to recognize that. And certainly with all the modern delivery techniques and technology, there should be no barriers anymore with regard to geography. And we can't expect individuals to travel to the great institutions, but they can't get to those cities. I think the other part goes back to the data issue, understanding and having those patients aggregated in so that we can look at populations of patients that might benefit. And that's another part of the futility success analysis. And then I'll shout out for ASCO. I think one thing that ASCO is taking very seriously is this idea of getting rid of the co-pays and the patient's participation in paying for their cancer care.
Yeah, couldn't agree more. And
I think, Tania, from my perspective, the first step was to be aware of this problem. Yes. When we are aware of the problem, it means that we can start working on that. So I think the first step has been done. I see two directions on this topic. First is short duration therapy. Part of the problem is the fact that treatment has become too complex, too long. So I think when a patient is presenting a cancer that is highly sensitive to a drug, we need to be sure we reduce the duration of therapy, because by reducing, automatically we reduce dramatically the cost of the treatment and we make it more accessible. So this is a major effort that we must do in the field of academics about de-escalation therapy. Yes. The second one, and Skip mentioned that, is about technology. We are discussing about AI. Probably AI is going to revolutionize access to treatment in low, medium income countries, because when we apply AI to images, maybe we can detect microsatellite instability, maybe we can detect all these features that define very high sensitivity to treatment. So I think for me, the two pillars, the two solutions are short duration therapy and moving easily accessible technology to some country where there is some issue of access.
How close do you think we are to being able to implement that? Or how receptive are treaters and researchers?
From my experience, in the few projects we did, I mean, we have a lot of engagement from everyone. I think everyone wants to go in this direction, and we have really good feedback from many stakeholders, including startup companies working on the field of AI, including government, including pharmaceutical companies. So I think everyone wants to do something. You know why? Because there is a major ethical issue behind.
Yes. Yes.
The major ethical issue is, I give you the example of immunotherapeutics for patients with MSI. It has become a major ethical issue that some patients in the world don't have access to this. I mean, this is a curative treatment for patients with highly lethal cancer. So we go beyond the general political question. It has become an ethical issue. So
Yes.
it's becoming very, very serious.
Yeah, no, I couldn't agree more. Your thoughts, Lillian?
Yeah, I guess I'll go more to the trial level. For every clinical trial, I think it'd be good for us to think about who are we recruiting, right? Do we need to have, for example, patient navigators and patient advocates, and to really understand how to make the trial easier and more implementable. Of course, we want pharmacokinetics every day for the rest of their treatment cycles forever and ever, but are they needed? And you know, how do we need every visit to come down to the cancer center? Can some actually be more local? And I think navigators can help with a lot of that, and obviously patient voices need to be heard. And sometimes when we review protocols, we think it's easy, but it's not. And I think having that kind of patient engagement and patient advocacy for every protocol would be very helpful.
Yeah, I mean, and to your point, sometimes when you look at a protocol, so much of it's just copied and pasted, right? Totally. And then you haven't asked yourself the question, how much of this do you really need? Or even having discussions with the regulators to say, do you really need all this PK data? Do you need all of this? Because now your patients are excluded because of that.
Yeah, absolutely.
So I'm going to do a quick round robin for a final question. You know, we have, again, this is really focused on HCPs, but we also have a lot of younger HCPs, whether they're fellows, residents, or just starting their career in oncology. I'll start with you, Skip, to go around. Any advice that you have for them, something that someone told you, or something that you picked up throughout your years?
Fabulous question and worth thinking about. You know, to me, the idea of finding that person who you really trust and looking around and interviewing the elders in your group, and they don't have to be a lot older, as to who you think is really going to be a mentor for you or a sponsor for you. They're subtly different, but I think it's worthwhile just not taking that person who might be in your tumor type or in your disease area. I've been very fortunate with those folks who've helped me, but that's got to be a two-way street, and I think it is worth really being diligent about thinking, who do you want to be that advocate to work with you?
I would say, while we want our early career investigators to focus, it's also important for them to also think out of the box sometimes, to learn something that you would not normally feel comfortable to sit in a lecture for, or read a book on, or read a paper on. Just sometimes it helps you stimulate that part of the brain that you haven't used because you haven't been thinking about that at all. And it could be applied back to where you want to focus. I think just be more what's the word? Disruptive?
Yes.
Transformative?
Yes. Yeah.
More out of the box.
Yeah. You know, there's something that I usually say to people, and especially to students, okay, if it has been done, then we can do it. But if it hasn't been done, then we must create it. And to me, as oncologists, we have to continue to push the boundaries, be disruptive, ask the questions, and actually, if there's no response, come up, find the answer, and continue to pursue it. So, couldn't agree more. What about you?
No, me, I think, Tania, I would really encourage young colleagues to go oncology, because I think it's really a specialty that can transform you as a man or woman, you know, because you are really, I mean, at the center, at the core of what is humanity, you know. I mean, you are dealing with patients. Some of them are going to die. So you really learn, you know, what is the most simple but most important thing of human beings. So I think it's, for me, it's really a specialty that has really transformed myself. So I really encourage colleagues to go in that direction. We know in this era where there is AI, complicated things, sophisticated, going back to the most simple and important thing that is, you know, human being, life, death, family, etc. I mean, we all need to go back to all these things now.
And with that, thank you so much. This has been fantastic. So, I mean, again, just thank you all for being here. And obviously, we have, to me, the giants in the field that have moved the needle. Seeing where you have moved the needle for patients, for people, for humanity is exceptional. So thank you so much for everything. Thank you for being here. Thank you for speaking and teaching and sharing your knowledge with the HCPs that will listen. I appreciate all of you, so thank you.
Thank you for having us.